Buzu, Kate Indigenous, Biktagon, Nishnabek, and Indoji. Hello, everybody. My name is Kate. My family comes from Pick River First Nations. I am an RN in the Mindemoyan Health Clinic and will be facilitating the Women's Health Talk today. Welcoming everybody back that's joined us before for the Indigenous Women's Health Talks, and a warm welcome to those who are new here. Together, we are gathered today to learn about women's medicine, menopause, and changes across the life cycle. To lead us in this knowledge, we have our Anishinaabe doctor, Dr. Alexa Lesprance. She walks her path in a good way and leads a two-eyed seeing approach to healthcare. We are very lucky to have her to teach us today on this important topic about our life changes. And so to begin, or before we begin, and in order to start us off in a good way, I am going to lead us with a smudge. So just asking that the creator sends this sacred smoke your way wherever it is that you're tuning in from. Right now, we are going into the fall leaves grandmother moon, and Mother Earth is blanketed with vibrant, beautiful colors that remind us of the miracles of Mother Earth and the beauty of letting things go so that we can heal and rest as the winter season approaches. I want to take a moment to calm our hearts and to quiet our minds and open our ears to learn these lessons. And to those of you that are listening today with a heavy heart or a clouded mind, I ask the Creator to offer you gentleness while you're listening to these teachings today. So then just a couple of housekeeping items for those who are joining us for the first time, and then just a reminder to those who have joined us before. In order to create a safe learning environment for all of us, you will not be able to turn on your mics or your cameras for other viewers to see. You can turn your cameras on and Dr. Alexa will be able to see you, but other viewers will not be able to see each other. If you have any questions or comments, put them in the chat. However, only our moderators will be able to see them, and these messages will be passed on to Dr. Alexa for her to answer. Around the halfway mark, we will have a 10-minute break, and a survey link will be provided at that time. We really, really appreciate your feedback on these talks, and it does very much help us plan for future talks or what we can do better or what you're enjoying. Everybody that fills out a survey will be entered into a draw for a prize. And this month, the prize is a self-care bundle. And also just a reminder that you don't need to fill out the survey immediately. It will be open for 2 days after the talk. So finally, once again, I just want to take a moment to thank Dr. Alexa for leading us in a good way on our learning journey. This afternoon, we learn about women's medicine, menopause, and changes across the life cycle. So if you're ready, I will pass the mic your way.
Participant screen share. So, here we go. Great. Thanks so much, Kate, and welcome everyone. Just a point of clarification, because we did sort of switch up how we stream these events. So actually, those that are, no one is really on Zoom at the moment because we don't do Zoom links anymore. I forgot about that. And so actually the ways in which you can watch this are on Facebook Live, Twitch, and YouTube. And so when you do include questions, comments, like those our moderators are watching those closely, and so they'll convey the question and just I can answer it as needed. We are, this is like a very informal in the sense, but questions are really like I'll answer. So feel free to send those my way. Let's see here. Great. So today's talk was and is related to menopause, but as Kate was mentioning, broadly to really just like the life cycle in general, the reproductive life cycle as women age. So I'll just introduce myself for people who don't know me. Anin Buju, Misabe Kwe Indigenous, Makwan Dotem, Bijnoa Bagzoging in Anishinabek and Donji, and Anishinaabe Kwe and Dao. So my English name is Alexa Lesprance. I am a family doctor. I am from the Bear Clan and originally I'm from Rocky Bay First Nation, which is in the Robinson Superior Treaty. And then partway through our life, we changed our band to My Brother's Reserve, which is Whitefish Bay First Nation. So I spent equal amounts of time growing up on reserve in both of those communities. I originally finished my medical school training at the Northern Ontario School of Medicine, which is located in Thunder Bay. And then to finish my family medicine residency training, I trained in Vancouver in the Indigenous Family Medicine program, which was really just a beautiful way to learn. A lot of my preceptors were Indigenous, so it was really good to learn from Native docs, just because there aren't a lot of us around. So it was a really, really well supported training. When I graduated, I practiced for about a year in Vancouver with Luma Medical, which is similar to Ontario, an Aboriginal Health Access Center. I also worked at Musqueam First Nation at the clinic on reserve, moved back to Thunder Bay. So right now that's where we're located. That's where I'm living. I live in Thunder Bay. Was doing some locum work in our region, and now I'm a physician for the Mindamoya Health Clinic at Onwa. I always share just a little bit about myself. One, because there is rightfully so a lot of mistrust within our healthcare system, and also like, who am I to be presenting this information? So I do want to just tell you a little bit about me so that it feels like this information can land. So I am Western trained in terms of having gone to medical school, and it took about 10 years to be a family doctor. It was a very long, hard, and arduous journey. It was just quite difficult, and in the same way that patients experience racism throughout my training, this is also what I experienced. A lot of times I wanted to quit. I said, oh, I don't want to do this anymore. But I persevered, and it was well worth it in the end. But it was a very difficult process throughout. I think our medical education really still has room to improve. I am on the board of directors for the Indigenous Physicians Association of Canada. So I'm the vice president of that. That is the organization that represents all the Native doctors, medical students, and residents within the country. And so the picture on the left-hand side is something we attended. It's called PRIDOC. It's actually the regional congress that meets every 2 years, and it's all of the Native doctors in the world, like, in Australia, New Zealand, Hawaii, the US, Canada, and Taiwan. So this was like all of, not all, but a pretty good representation of all of the, Native people across the world and in our neighboring Indigenous communities who also practice medicine. So it was a very beautiful experience. I myself grew up in a very traditional family. whether it was in regards to ceremony or just even like land-based activities like hunting, berry picking. Both sets of my grandparents are really knowledgeable about that, so I sort of grew up in that way. So the bottom left-hand photo is my sister, my papa, and my kukam, all of us building our sweat lodge, which we do every spring and fall. The right-hand photo is me harvesting some bark. So I am not a traditional medicine person, but I do know a bit and have been learning about traditional medicines probably about for the last 5 years. Still very childlike and really just being able to identify and even just having relations with all of those plants. So it is, I say that I like know a bit about traditional medicine, and that's a part of my two-eyed seeing, but I really have so much more to learn and really don't know a whole lot. So today's topic, I think it was requested quite a while back, and I think it's because it was something that's not often talked about. So, sometimes, so menopause, sometimes referred to as the change or the time when your moon or your period stops, the old lady stops visiting. There's kind of all of these colloquial understandings of menopause, and just generally it's not necessarily talked about, and so this is why we're doing this today. Some things that just from my own learning and understanding of our bodies and our reproductive lives, menopause, it has become very medicalized, in the sense that there are a lot of medical treatments to help reduce like symptoms and suffering if that's happening. But menopause is not actually a disease. It's a transition period. And the majority of women and women identifying people go through this change throughout their lifetime. Sometimes people are like, well, I probably skipped it, or like, I don't know if it happened. That really just depends. But it is a transition period. And I do think it's a beautiful transition period. Similar to, like, I think of, the first time you have your moon or your period, or if you've ever had children, when you deliver those children or you birth them, or I just think of this as a part of the cycle of women's lives. And so similarly, menopause is a time where, your relationships might be changing with your body, with yourself, with other people around you. I find that menopause is also a time marked by acceptance of aging and change. Menopause is a time ideally for rest, and increased focused on self, and really just a time of freedom as well from childbearing and the constraints of women's roles, if that's what you have been doing up until this point. So a lot of people sort of are scared and think like, oh, it's just going to be so terrible. But there are really a lot of benefits and a lot of beautiful things. Like, I think of some of my patients who are like, they were postmenopausal and thinking like, I actually don't need to worry about participating in ceremony because I'm never on my moon. I think of, like, there's activities where I'm like, oh, I really want to make sure I do that. I'm still in my child reproductive potential years, and then not being able to do that, and just, because maybe you've if children are in your family and now you're a grandparent, right? There's this focus on like grandmothering or grandparenting, and I just think that there is a lot to be learned, and a lot to look forward to in regards to menopause, whether that's spiritual changes. I find it's being able to connect to yourself becomes a bit easier because you've been in your body for 60 plus years, by the time you've finished menopause. So I think there is just a lot of beauty and wisdom, and that's when people think of menopause, and the change. There really is, I think, a change in terms of how you see yourself and just the wisdom that you've accrued over time. So, as I said, menopause may also mark the transition to becoming a grandmother and prioritizing time for grandchildren, as well, an evolution from learning to teaching cultural ways. I find that lots of women, because you've been practicing and you've been learning, and so now you're kind of in this phase where you've been practicing culture for so long, and now you're sort of teaching it, and you're taking up maybe more teaching roles or doing more activities to try and get young people involved, and really a time when women do gain greater respect within the community. I do think of women who have gone through menopause, and being on the other side, like they've really entered the majority of their reproductive life cycle, and there's just so much wisdom that was garnered in all of those years. So something we do have to be aware of, and probably why this topic is often not talked about. Like if I asked, there were some patients where I was like, hey, like, they were going over all these symptoms they had. I'm like, it sounds like you're going through menopause. And they're like, what? And I'm like, yeah, like everything you're describing really sounds like menopause. And they're like, oh, my grandma didn't talk about that. It was just kind of hush hush. And that is somewhat related to like colonial and religious oppression of Indigenous people, which created a bit of discomfort and taboo-ness around sexual and reproductive matters. Also, I think of the sexual violence that's been experienced since Canada has been colonized, abuse that happened in residential schools, incest within families as a result of learned behaviors that children learned while in residential schools. And so there's a lot of really compelling reasons why people might find anything related to do with vaginas, with sex, with women's health topics in general to feel very jarring. And I think that is learned from the people who have colonized our country, and does have religious undertones because historically, there wasn't really this sense of like, no, we don't talk about this, or no, we don't know a lot about this. Lots of that wisdom was shared and it was celebrated. So, but there is a lot of it makes sense why sometimes topics like this can be uncomfortable, but also why we then need this type of information. So I want to start by talking about language and what menopause, like when we say menopause or when I say menopause, what exactly I mean, because there's kind of menopause is kind of used just generally to describe the entire transition. People say like, I'm in menopause, or like, oh, I'm experiencing menopause. But technically, terminology wise, menopause is like a singular moment. So, and it's the singular moment in time when you realize that you haven't had a period in 12 months. Right? So everything before that, the perimenopause, which is everything that was before, that can last anywhere from 4 to 10 years. Sometimes people are like, I feel like I've been in perimenopause all my life. Like it's like been, it's really can be frustrating for people who are on that 10-year end of the spectrum. But in reality, all the symptoms and discomfort that the majority of people talk about when they're talking about symptoms is usually actually occurring in perimenopause, and it actually starts to get better once you hit menopause and then once you become postmenopausal. But just this concept of technically you're not in menopause, you've hit menopause. It's kind of like you were going perimenopause, and then the 10 seconds that it took you to realize, oh man, this is like I officially have not had a period, you realize that the next moment later, you're postmenopausal. Congrats. So just, yeah, it's a one key event that happens. But I mean, it makes sense just to simplify that we're just referring to like everything beginning, pre, post as just menopause. I'm in menopause. But the reason why I like to distinguish that is because it helps communicate to your healthcare providers when there's potentially a problem. So people will say like, well, I'm in menopause. What about all my symptoms? And I was like, yeah, your symptoms probably started when you're in perimenopause, all the time before. It was there, the 10 seconds you realize that you hit menopause, and will likely continue as you're in the menopause phase. So it's thinking of menopause as an event, and that's when you realize versus the entire transition. And so sometimes, like, because you could have had menopausal symptoms, like hot flushes and night sweats, any time during this period, but it's just menopause is the moment you realize, yeah, I have no, I've had no period, you know. But the concern that there is when we just kind of generally describe this as, oh, I'm in menopause, is then we don't know when to say that we have had postmenopausal bleeding, right? So if after 12 months you've had no period, that's it. That's menopause. That very moment that it's like you realized you hit the 12-month mark, you were in December, and then the next December you're like, I've had no bleeding, I've had no periods. That's officially you have hit menopause, and then the next moment you're postmenopausal. So in the event that you had vaginal bleeding, like say 2 months after, you're like, oh, it's been a year with no period, great, menopause. And then 2 months later, all of a sudden you have bleeding. That's actually not a period. That is now vaginal bleeding, which is concerning because people who have bleeding after their periods are supposed to be done, 10 to 15% of them have a chance of having endometrial cancer. And also when people, it's good to keep track of when your bleeding stops and ends, because when people say, oh yeah, like I ended menopause, like, I hit menopause like 2 years ago, and now all of a sudden I have bleeding, like maybe my periods have come back, and it's usually that's not the case. And if it is, you know, postmenopausal bleeding really requires prompt evaluation to exclude cancer in the genital area or any like sort of precancer stuff inside the lining of the endometrium. There's other reasons why people could like have bleeding after they've hit menopause, like the vagina starts to, the skin of the lining starts to get a little bit thinner, so you kind of can develop almost these like little paper cut irritations. Sometimes people have polyps or fibroids. Definitely the prevalence of polyps, which are just like really overgrown little things that are kind of sticking off, is up to 40%. So bleeding in and of itself isn't bad, but it's just like not a thing to sit on. Like don't kind of like wait, like, oh, maybe it was just a one-off thing, because I do think it's worth investigating right away. Just because it's a bit of a process, right? So like if we knew that, oh, I've hit menopause and now there's bleeding 3 months later, we want to make sure, okay, was your pap, your cervical smear, your cervical screening normal? When we put a speculum inside, which is kind of those ducklet things that you insert to sort of look on the inside, in order to see the cervix. Okay, does that look normal? Yes. Okay. Well then, if that's normal, then why is there bleeding? If physically what I'm seeing. And so what sometimes will happen is people will need to go for an ultrasound. That's what's on the left-hand side. And to look at the endometrial thickness, like how thick is the lining of the uterus? Because sometimes that can be an indication of if something is growing really, if the lining of the inside is growing really rapidly, that can sometimes be a sign of cancer. So they actually measure that, okay, is it less than 4 millimeters? In which case it's okay. Maybe it was a one-off bleeding. We don't maybe necessarily need to investigate this further, versus, oh man, there actually was a bit of bleeding and you've hit menopause already. And so then, we'd say like, okay, we really want to make sure this is an endometrial cancer. So they would have to, go in, get a sample inside the cervix. And depending on what the results were of that sampling, there's kind of different algorithms to go through. So I always just tell, because sometimes people will come in and they'll say things like, oh yeah, like I've just had like, there was a whole year where I didn't have a period, and now I just kind of have spotting, which is weird, but it's probably just menopause still. But remember, you hit menopause when it was the full 12 months. So anything after that is postmenopausal bleeding. And I really don't want people, because this is what happens. And then I'm like, wait, how long have you been having this spotting? Like you already hit menopause. Like it's official, it's confirmed. So any bleeding outside of that is abnormal. And they commented like, oh, it's been like a couple years. And I'm like, no, don't sit on that. Don't like wait to see someone about that. Just go. The other thing that while I'm sort of on the topic of like don't sit on it. That means like don't wait, and just like hope that it gets better. Go and actually see someone as soon as you can. But another thing to related to menopause and bleeding, where I would encourage people to actually go and see a provider, pretty promptly, is depending on how young you hit menopause. Like a lot of things in menopause or the change, age doesn't necessarily matter. Like it's kind of like, I don't know, some people hit it when they're 51 or 52, or sometimes like their perimenopause started when they were 40, right? But there's actually if you have hit menopause before the age of 40, then that's actually a medical concern. That's called premature ovarian insufficiency. Because sometimes people say, "Oh yeah, I hit menopause when I was like 35." It's like, what? That's way too early. And the reason why that's a concern is because it's in your best interest, health wise, to have your body exposed to your own estrogen, your own natural estrogen, for as long as possible, because then you avoid side effects, then you avoid the complications like bone health issues, heart issues, right? So it's not actually the good to get menopause, to have hit menopause quite early, like less than the age of 40. And even if you did, you're like, oh yeah, I hit menopause and I was 40, 40, 41. That's not premature ovarian insufficiency, but that is sort of an early age, um, relative to when people on average do hit menopause, that singular moment, which is around age 51. So there's lots of reasons why people might, for example, hit menopause and be less than 40 years old. Some of it, like, is genetic. Some people have Fragile X or Turner syndrome, which is essentially genetic conditions where people to start with had a low number of follicles in the ovaries. Sometimes autoimmune, so like you hit a menopause way too early because you had Addison's disease or you had like thyroid issues. Sometimes it can happen because of infection. So you had really bad mumps or you had HIV. And the idea is that when a cause as to why someone might have this premature ovarian insufficiency was because the antibodies, the idea is that the antibodies potentially attacked the ovaries. Idiopathic, so that means people don't know why. I think of environmental toxins, so Indigenous people are more likely to be exposed to environmental toxins from extractive resources and mining, logging, all of these things. And so as a result, due to your environment, you actually may have hit menopause very early, and unnaturally because of the environment. I think of like different chemicals and the pesticides we use, but even just in like toxins in the sense of like cigarette smoke, right? Or like smoking. Sometimes people hit menopause because they had cancer, and for chemotherapy and radiation, that's just, when you're trying to treat cancer and you're treating everything, and therefore there's the potential for things to get destroyed. For example, like your ovaries, and the follicles that are inside of your ovaries. So sometimes, people are like, I'm in menopause because, well, I had this cancer treatment. Same with surgical. So there's a medical procedure called an oophorectomy, which is when they remove both of your ovaries. So sometimes people, like, I don't know, will have a mass or something on one of their ovaries. And so you're like, okay, that was really concerning. We need to have that removed. You still have one ovary. That's fine. You're going to go through natural menopause like everyone else. But there are times where people, like, it's like, this is actually really dangerous. Maybe they see two things on both ovaries. You need to remove both of them. Once those are out of your body, that's menopause. You've created it surgically. You've surgically created menopause. This is relevant too also for our trans folks who, like, they have surgeries specifically where you're removing the uterus, the fallopian tubes, the ovaries. It's called a histiosalpingio oophorectomy, which is just a really dumb long name, but it's essentially when you remove everything. And some people intentionally do that because they don't want the estrogen from their eggs, right? If you're a trans man and you have ovaries that are constantly producing estrogen and you're trying to take testosterone to tell the estrogen, hey, stop, I'm not a woman, I'm a man, then it's actually a medical treatment to remove those ovaries so that you don't have an estrogen store. But what people might not necessarily realize is that when you do that, that is essentially like you have hit menopause at that point in time. And again, if you're really young when this happens, like say you had this surgery where both of your ovaries were removed when you were 21, that means you've hit menopause like 30 years like before you should have, which is very unnatural. And your body really depends a lot on estrogen and progesterone, which are the two main hormones we're going to talk about. So it is very relevant to know the age in which you hit menopause. Um, so to go back here, so before the age of 40, definitely, unless it was caused, it was well known that it was caused by one of those. Like you had the surgery, you had the chemotherapy, right? You have the genetic disorder. Still see a provider so that we can talk about the preventative things. We want to prevent harms from happening because that's 30 years that you lose out on, where your body would have normally been having the estrogen that your body needed. So still talk to someone, but if it's none of these things and you're like, oh, I don't know why this happened, please just talk to somebody. The other is early. So if it was less than 45, I'm kind of like, bizarre. Was it any of those things on that list? Like, was it due to environmental toxins, infection, things like that? But it is still worth seeing a provider to get a workup so that we can figure out, why did the person hit menopause early? Sometimes what might happen is that people who have a lot of body mass, like people who have concerns with obesity, sometimes they go into menopause early, and it's related to estrogen. So less than 40, not ideal. 40 to 45, I'm like, okay, that's okay, but like let's maybe look into it. And then when I say menopause, I mean the moment where it was the 12-month, oh, there was no period whatsoever. Because all the like if you're like, oh, I started perimenopause, I started getting hot flashes and blah 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 when I was in my 40s, that's okay. That's completely normal. It's just when you've hit that singular point and you're like, oh dear, I'm 25 and there's been 12 months where I've had no period and I'm not pregnant. There's not another reason why someone is not in menopause. But usually the sort of like typical age is around 51. That's where like, okay, periods have stopped. Having menopause, hitting menopause late is considered anything after 55. There's not necessarily harms involved with that. If anything, you kind of got like some bonus years because you got exposed to the natural estrogen your body was producing. So it's actually a benefit kind of to have your age that you're hitting menopause to be later than 55. Like, good for you. You had like some extra years. Yeah, so that's what this is about. So getting menopause early means less time your body was exposed to estrogen, which means you have a longer risk of osteoporosis and heart problems. And so you would really need to focus on calcium and vitamin D, which are the things that we will talk about more. While it may be natural for menopause to occur at a later than average age, prolonged menstrual bleeding after periods have begun to diminish may indicate abnormal growth. So I know that's the thing with menopause is the thing that is well known and will happen 100% of the time is that we don't know what's going to happen. People experience different symptoms. They get symptoms at certain age. They hit menopause at certain age. So there's kind of lots of, and that's probably why it's also difficult to discuss, is because it's kind of confusing, where it's like, yeah, it is good if you hit menopause a bit later, but like not too late, because then we're like, why are you still bleeding? Like, is there a fibroid? Like, especially if, say age 55, you hit menopause and then, or sorry, you were in perimenopause, which is all the stuff before. It's like where you're having the weird bleeding that's on and off. then, and it was starting to slowly become less. Now you're like 56, and then it became really heavy all of a sudden. That's a bit bizarre because you're out of the perimenopause age where you would expect to be perimenopausal, and are kind of in the where you should be postmenopausal. So it's okay if it's still taking a while, but if all of a sudden there's this huge shift in flow and you're above the age of 55, it's kind of like, we should think about that. Doesn't mean something bad is happening, but just see someone about it. Hormone levels, they fluctuate throughout the entire life cycle. So, like I mentioned, estrogen, progesterone. So, we think of when you are born, right? You have a set amount of estrogen, which is not very much, right? As you go through puberty and you have changes like where you get your moon time or you start to develop breast tissue, you maybe develop pubic hair, all the things related to puberty, the estrogen and progesterone is like whoop, whoop, whoop. And that's why people say like, oh, teens, like they're so moody. And I'm like, well, their estrogen and progesterone is like really going like this. So who wouldn't be? But it's slowly you're getting more and more. Then you're kind of in your fertile or reproductive years, which is really from any time you started your period up until about age 35. After age 35, people still are like have kids, no problem, especially native. Like there's people who are like 45 and they're like, I had my fourth baby. Like, good for you. You're really fertile. But there is just sort of that's the peak. That's when it's going to be at its highest, right? And so there might be a bit more energy to rear children. So the estrogen and progesterone, it peaks in those like in your 20s, 30s kind of thing. When you start to hit perimenopause, you can kind of see these squiggles, right? Where it's like going down, going down. Oh, now it's going up, going down, going down. Oh, now it's going up. So this is why perimenopause can actually be really frustrating is because you're like, oh, nice, there's no bleeding. Now there's a bleeding again. Oh, now there's none. Oh, now my mood is good. Okay, now it's not. Oh, now I'm hot and now I'm cold, right? So it can be really frustrating, but that's what's happening. Then there's menopause, right? You can kind of see it's the singular event. Okay, this person realized that they had 12 months with no period at this point in time, and then the estrogen and the progesterone declines, it plateaus. You just have you never have zero estrogen in your body because other organs will kick in and they produce estrogen. But the majority of estrogen and progesterone comes from your ovaries. The reason why things like getting your period or going through menopause or hitting menopause and even like pregnancy, like why it just seems to be there's whole body effects is because those hormones really do affect almost every body tissue. So they're mostly in charge, estrogen, growth of organs, whether that's growing breasts or pubic hair, controlling metabolism, and someone's production. So it controls estrogen and progesterone controls when you do or you don't have periods, if you can get pregnant, and then the lack of it is when you've hit menopause. But it very specifically also affects these areas. So your chest, or as some people might refer to it, their breasts, your vagina, your bones, your blood vessels, your GI tract, which is like everything related to your stomach and bowel, and then your urinary tract, which is like your bladder and peeing. So when you look at what these hormones affect, it kind of makes sense when we talk now about menopausal symptoms, people, or even pregnancy symptoms, right? Oh, my chest, my breasts are very enlarged, they're very tender. Oh, my blood vessels, they've gotten thicker, and so now I actually have more swelling in my body. For peeing, it always feels like I have to pee because you have a life that's growing within you and it's putting pressure on your bladder. So it affects everything. I just feel like estrogen is kind of this miracle hormone that you have that just does a bunch of things for your skin, for your hair, for your mood, but it very specifically also affects these major bodily processes, which explains symptoms for menopause. So once you've, so I included this image because you can have a high amount of estrogen and a low amount of estrogen. So, and when I describe them, you'll be like, oh, that I remember a time where I probably did have high estrogen. So I'm just gonna zoom up in this 1 second here. Um, so excess is essentially um, wait a second here. I'm gonna just zoom out of this and go like this. Sorry, folks, I'm just sharing the screen in a different way because I was silly and I can't see my own if I am like not out of this particular thing. Um, because having too much estrogen or too much low estrogen, people can run into problems. So you might be in a state of high estrogen when you've had weight gain, especially in your waist, hips, and thighs. You might have, when you have high estrogen, you might have menstrual problems like light or heavy bleeding. Maybe your PMS symptoms get worse. People who have fibrocystic breasts, which are it's like the non-cancerous lumps, and when people say, "Oh, your breasts are really dense," that's what they're talking about is fibrocystic breasts, and essentially it's not cancerous, but there's just bumps and lumps that kind of make it lumpy, and that's because of high levels of estrogen. Sometimes when you have high levels of estrogen, you can develop fibroids, which are non-cancerous tumors. People get freaked out when they hear the word tumor, but it's not actually, fibroids aren't cancerous. Tumor just means overgrowth of something. People can develop mood swings. They might feel really depressed or anxious. Their breasts might swell and be tender. You might have low sexual desire, feel really fatigued. And then there's even like when estrogen is high in men, right? You might have poor erections, loss of sex drive. And so when you look at the highs of estrogen, it's almost like I'm describing when you're on your period or when you're pregnant. Like, especially with like the weight gain and the depression, the anxiety, the breast tenderness, and same with the lows of estrogen. So the common reason for low estrogen in women is usually menopause or surgically having your ovaries removed. And so signs that you right now have low estrogen is your menstrual periods are less frequent or they stop, that you have hot flushes, trouble sleeping, or maybe even vaginal drying and thinness. Some women get migraines right before their periods, like they'll have the worst headache before their periods. That's usually actually due to the drop of estrogen that happens right before your period. So that's like a symptom actually of having low estrogen. So I talk about hormones more broadly because it just really helps us understand symptoms, but all symptoms and things happening in your body are really related to these particular hormones. Thank you, tech team. Very sorry that I am switching my views. Sorry. I'll adjust it here. Is that okay? Yeah, okay. Great, that's my bad. I will know for next time not to include really small graphics in this particular view. So the menopause map. I think this is helpful to figure out where people are. Like, where am I on this map? Even myself, I was like, where am I on this map? But it's just that, the beginning of menopause and the transition, it takes time to progress through each stage of menopause, right? Whether it's peri or post. And so I think of the late reproductive phase. So that's even like people who are around age 35-ish. So in about 5 years, I will be entering in terms of my menopause map, the late reproductive phase. So this could mean that, my periods right now, they're regular, but there's like really subtle changes. Like maybe they last just a couple days more, or they last a little couple days less. Cycles might be shorter. You might notice like, oh, the flow is kind of becoming a bit different, or your PMS, which is your like the mood before your period is getting worse. You might be like, oh, my memory is a bit off. Um, and the graph is funny because it says, no, you almost certainly do not have dementia. So if at age 35 you have memory issues, highly, highly unlikely that you have dementia unless it was vascular dementia and you would know because you would have had a stroke. No, 9 times out of 10, like when people are like, my memory is going, there's a difference in terms of cognitive function versus memory. So oftentimes when people are like, I forgot where I'm putting things down, that is like a symptom of decreasing estrogen. But this happens, around 35. You're no menopause in sight, but you're starting to notice things in your body, and things in your life might be starting to change. Then there's kind of the early perimenopause, which is everything that comes before. And you kind of know that you're there when your cycle length really starts to vary by like 7 or more days. You're like, oh, this is like extra late, or this is extra early, my period. And then the length of time in the phases of being early menopause, it kind of just changes. But things have moved on. Like there was a bit of a change in the late reproductive, but now it's turning into actually perimenopause, which is where people start to develop more symptoms. So versus late menopause, perimenopause, and that's where people, I think, really are in the heat of the like, oh, my hot flushes, like I'm so moody, all of the symptoms that we'll talk about that are related to menopause. Late perimenopause is usually like around your mid to late 40s. And it's defined by going 2 or more months between periods. And this phase usually lasts about 3 years. Remember I said early, like the stage of perimenopause can be anywhere from 4 to 10 years. It doesn't really make a lot of sense to try and break it down of like, well, I spent 4 years in early perimenopause and 5 years in late perimenopause, because it's all just kind of grouped as one. The only thing that's concerning is how early you get that, because then you might have to deal with symptoms sooner, symptoms that are bothersome. So you can kind of see here the hot flushes and night sweats most likely are when you're late perimenopause, when you've hit your final period, the singular moment in time, or you've hit menopause, and then everything post-menopause, right? That's the period in which you are likely going to develop symptoms. So when I talk about symptoms, this is when you're probably experiencing them. So early post-menopause, yeah, 5 to 8 years after your last period, right? So like you knew you were menopause, the moment later, now you're postmenopausal. But it's been 5 years since you've haven't had a period, since you've hit menopause, right? So now, okay, like that's okay. You are probably starting, your hormones levels might be getting a bit worse, but then eventually they start to settle, and they will start to get better in late postmenopause. So I kind of have the age here, average age 51, you're kind of postmenopause 51 to 60-ish. These are all ranges. And again, the age doesn't matter unless you hit menopause very, very early. And that's pretty much the only time that it really matters. And then there's kind of like little tidbits and little caveats if depending on the age and your family history and stuff like that. But it really only matters if you've gotten it super early, which is less than the age of 40. But if early to mid 40s, we were just in early perimenopause, which is where all these like shifts are happening, that's okay. That's not dangerous to us. And maybe not the greatest in terms of your symptoms, but it's okay. Same with like mid to late 40s. Yep, still in perimenopause. Like that's not a big deal. And some people, depending on the women in their family, that usually dictates what your menopausal experience is going to be like, is depending on what other women in your family have experienced. But I find kind of right in this late perimenopause and early postmenopause, that's usually when the symptoms are quite a bit worse. Um, so let's see here. What else? Yeah, and so late postmenopause is usually you're 60 and up. So by that point, by the time you're 60, you've hit menopause many years ago. You slowly transitioned out of the symptoms because you were postmenopausal, and now you're like late postmenopausal, which is, many years out, and then your estrogen really has started to drop. And I find the usually the 60 and up, that's when people start to have more vaginal symptoms like the dryness, or needing to pee more often, like the incontinence issues. That's usually around the age that people start to have those types of problems, is like they're late postmenopause. So, what are the symptoms that I'm talking about? The symptoms throughout the transition, during this whole cycle from early, late, and then menopause, this whole range. The symptoms that I'm referring to are these. So, there's the vasomotor. That means hot flushes or night sweats. People might have changes in their mood, like premenstrual syndrome, irritability, difficulty coping. People can develop depressive symptoms or increased anxiety. When you've hit menopause or in this, transition in your life, you might have like a hard time sleeping. So either not getting enough sleep, not feeling rested after your sleep, or just being so hot at night that you're just too sweaty to sleep. Genital symptoms, so the vaginal dryness, and maybe even a bit of like the vagina being a little burny or irritated because of the dryness, right? Because estrogen helps keep, I don't really like this word, but it keeps the mucosa or like the lining of your vagina moist, like wet. And so when there's a bit of moisture in that area, then you're not really going to have these little kind of paper cuts or these friction bits on the vagina. So then, you're not going to have as much burning and irritation. Sexual symptoms, so reduced sexual desire or arousal, poor lubrication, which may result in painful sex. People in this life transition across the board, they might have peeing symptoms where you feel like you have to, when you're like, oh, I have to go and I have to go immediately. It might even be painful to pee, again, because it's so dry down there. And even getting recurrent bladder infections, because when it's so dry all the time, it's kind of like your body isn't as great as fighting off infections that can travel into the urethra. Like there's lots of stuff happening when you're wiping down there or you're going to the bathroom, right? Like because so many different things are down there. So if a bit of fecal matter or bacteria from like someone giving oral sex, or you've gone to the bathroom and you accidentally like wiped from the back to the front instead of front to back, even just a little bit of bacteria, I find, or like you ate too much sugar and now you have a bladder infection, right? I just find that people in this transition are more susceptible to bladder infections because of that. People start to get brain fog or find it really hard to concentrate or to learn new things. And again, the memory, unlikely to be Alzheimer's. But memory, you're just like, wait, what am I doing again? Wait, what am I doing again? Wait, where did I put that thing? And so that might seem alarming, but it is actually a part of the what happens when you have less estrogen in your body. Some people start to gain weight around, especially around their hips and their stomach. Joint pain, that's one that commonly people don't know about because there's kind of this like, well, as you age, you just like are more creaky. So when you get up, it's kind of like, oh, like, you're just a bit more sore. That is a part of aging, but joint pain specifically can also be a symptom of menopause. Same with heart palpitations. So you can see there's like a bajillion symptoms of symptoms that would happen throughout this change in your life. And so many of them have other things that it could be related to, right? Like joint pain. Don't just assume that it's your like menopause. Like maybe it's rheumatoid arthritis. Like, there's a differential diagnosis, which means there's other potential causes of all of these things. But it's just I explain this in depth and I talk about this to show you the range of symptoms there are within this change. And if you kind of have a constellation of all of these things, you probably hit or are about to hit menopause. You're either in the perimenopause stage, hit menopause, or you're post, somewhere in that cycle. And oftentimes that gets overlooked. Like sometimes, you'll have done this workup for like so many different medical issues. You're like, well, it could be this and it could be this. And you're like, but nothing's wrong. What's going on? And we're like, oh, you're probably in menopause. And that's what I mean about the over medicalized nature of this, which is like, we want to investigate if there's something that's bothering you. Of course, talk to your provider, but often it's just sometimes so obvious that you don't even really realize, like it's overlooked because of how obvious it could be. But so we want to be in a place where you're feeling not listened to by your provider because they're like, oh, it's just menopause. Like you don't want to experience this attitude of not caring about symptoms, but also knowing that this constellation means that that's probably happening. Sometimes people will ask about blood work related to menopause, and unless you got it less than the age of 40 or you got it early, kind of less than the age of 45, blood work isn't actually very helpful. And that's not actually the thing that diagnoses menopause. The thing that diagnoses menopause is actually that 12-month mark. Like you've kept track and you haven't had a period in 12 months. So the kind of like, well, I just want to know what my hormones are. Like I sort of get where patients are coming from when they want this. And again, it's a conversation I have with all people. If they're like, oh, I want this, I'm like, okay, yeah, sure, we'll do that. But for some people, it is like not super medically helpful, especially when we think of perimenopause where there's all these fluctuations. So like your hormone level will change the next day. Like if we did your blood work one day and then the next day, right? And it actually is unlikely to tell us anything. So I don't really standardly across the board order blood work for people because that's not how you diagnose menopause. So this is an example of like symptoms that could be bothering you and then how much they're affecting you, whether that's not at all, a little bit, quite a bit, extremely. And so I find that this is helpful, again, because we want to know about the constellation of symptoms. So if you Google like menopause symptom calculator, this is probably what will come up. And this is just to keep track, like, am I experiencing these things and how often? Just so for your own awareness to know what's going on, right? When things are happening to our body, there's obviously the human nature is to be like, well, why? Is there something wrong? Right? So it makes sense that we want to know these things. These are definitely the symptoms that people, when they've done studies, that these have been the most impactful. The hot flushes, the weight gain, and sleep, right? Which makes sense. Like if you can't sleep, your whole day is ruined. Like you're not productive, you're grumpy, you're irritated, like, and then, things take more time. And then the next day there's a pile of stuff to do because you weren't able to do it the day before, right? So sleep across the board. When people can't sleep, that's something I take really seriously because it messes up your whole day and your whole life, not being able to sleep properly and not being able to get rejuvenating sleep. The weight gain makes sense more so in terms of women and their body image. I like to remind people that weight actually has nothing to do with your health, and it is not actually a marker for if someone is healthy or not, right? Someone could like be the like super, super skinny, but actually like what they're eating is pop and chips every day and they never exercise and they're not sleeping well versus, someone who had a really, really high BMI and they're like eating really healthy, eating really well, they're really strong, they lift a lot of stuff at the gym, right? So weight, again, doesn't really have anything to do with your health status because health is how you understand your world and your body. But because of how weight is perceived, especially on women's bodies by society, it's more the mind that's affected, right? Like, oh, I don't want to look fat. Oh, I'm tired of looking fat. And then it's like, that's not actually a bad, like, that's not, it's not an indicator of health. But I get, because of how women are socialized and because of the media that we receive, there's this concept that being smaller is better. And I just challenge that idea because I don't think that's actually true. Um, and then the hot flashes, right? Like I think of the times even in the summer where I'm really hot because the weather's hot and I'm just so miserable. Like nobody wants to be around me. I'm just like, oh, don't even talk to me. I don't want to do anything. Like I'm just so hot, right? So it makes sense that those would be the most impactful symptoms, which is why we have treatment options mostly for these things, right? Related to menopause because they seem to affect people the most. Um, we are at 4:05. Oh, what else am I talking about? I still have hot flashes that I want to go over, plus like some breast screening stuff. But do you think, because it's the halfway mark, we should take a break? Sure. Okay. Okay. Oh, and yeah, sorry, I'll answer questions first. That's a great thought. And then we'll break for 10 minutes. Okay. So, are there questions? Thank you. What if you've had an endometrial ablation? That's a really good question. So, having an endometrial ablation, that's essentially where they've gone in and they've cauterized the inside lining of the uterus, right? Which is a very invasive word, cauterizing, but it's literally where they're burning out the inside of the lining. That wouldn't necessarily affect menopause because menopause is related to your ovaries, right? And in an endometrial ablation where you're taking out that lining, you're not taking out the ovaries, right? The ovaries are still staying in place. What it might affect is your hormone levels, but usually if people are getting that ablation, it's because they have lots of bleeding, which is they have lots of estrogen. Like their problem is lots of estrogen rather than a little bit of estrogen. So it would not really affect the age in which you hit menopause, but it might affect your periods, right? So, because if all of a sudden you've had this ablation and nothing ever grows back, and then you're kind of like, well, wait, when did my periods stop? You wouldn't necessarily know, but usually after people get ablations, the lining still grows back for the most part. Or eventually it will. For the most part, there's not really a permanent way to get rid of the lining, but I understand like might be difficult to figure out when you've hit menopause because you're like, well, periods are the shedding of the lining, and if the lining doesn't exist anymore because you've burnt it all off, then how would you figure that out? And I think that's an instance where you would probably need to rely on blood work in order to figure out when exactly it is that your period stopped. But just because the periods stopped does not, like the lining, the bleeding itself has stopped, doesn't mean that the ovary releasing a follicle and that follicle going to your lining, trying to find a place to implant to have pregnancy, like that process is still happening. Um, it's not super great because the egg is coming out of the ovary and it's like, oh, all of this stuff is burnt. It's like I have nowhere to go. And then I am going to release. But then you might not bleed as much or you might not have bleeding, but the actual ovulation process is still happening. So even if there isn't bleeding. Okay, is there another question? Okay, great. So let's take a 10-minute break. So it's 10:08 or 4:08 now. So at 4:18, we will come back and then we'll go through the rest of the material. And if you have any questions, put them in the chat because when we come back from the break, that's when we'll answer those questions. Okay, be back. Welcome back from your break. We have audio, this is good. So the next thing that we were going to talk about was hot flashes, but first we're just going to answer a question, which is, do we still get menopause if on birth control? Yes. So you would still be hitting menopause when you're on birth control. The issue is that you wouldn't really know when it was, right? So you'd kind of have to be off birth control to then see, okay, did my period stop for a 12-month period? Because because otherwise, actually, being on birth control is like you never going on menopause, right? Because you're just kind of like consistently taking the estrogen, and that's actually one of the birth control is a treatment to treat menopause so that you treat the symptoms and almost like prevent it from um, happening. Does eventually the age of your ovaries get really like quite a bit older, and then you run out of eggs? Yes, but you wouldn't really be able to tell because the birth control would kind of be like messing up your period. So sometimes when people are like, is this my birth control or am I on menopause? We actually like take a pause on their menopause or their take a pause on their birth control just to see like, because otherwise, you're just kind of, you would never know, right? Because some people on birth control don't even get periods anymore. So you're like, oh, I must be in menopause. But it's menopause is a natural phenomenon unless surgically done. So you actually would need to stop birth control in order to officially confirm if you have hit menopause. Okay, is there any other questions? Okay. So, hot flashes being one of the main symptoms that people are really affected by. 60% of women in the US are affected by this. How people describe it is a sudden sensation of intense heat that's usually in the upper body or all of your body, and it results in like a flushed neck or red blotches on your neck or your body or your skin. And so your heart races, your skin temperature increases because blood flow is pumping. So, do you remember how we talked about how estrogen and progesterone they affect like everything in your body, but it especially affects certain things? One of those things was blood vessels, and so this is why this is a symptom of menopause because of the lack of estrogen. Because when you because there's more blood flow that's happening, that's why the heat rises to the skin, or people get red really quickly in their face. It's related actually to the size of your blood vessels. So when people get really, really, really hot, right, they start to sweat because your body's like, why are you getting really warm? We need to cool you down. And the way that it does that is by sweating and then shivering, right? Because it's like, use up this heat, stop being so warm. So that's why, so this is why the hot flashes are usually then um, preceded by the shivering and the sweating because you're like, oh, I'm so warm and now I'm so cold, and that's because in an attempt to thermal regulate, which is a way of just saying to balance your internal temperature, your body has a few ways that it can do that, and one of those ways to make you warmer is by taking blood flow from your heart and distributing it to your hands and your feet and your toes and your face. Hence, and then ways that it helps make you cooler is, by sweating. Okay, let's try and get rid of this heat. But there's just this, I don't know exactly what the precise mechanism is, nobody does, but there's this idea that the falling estrogen releases higher amounts of hormones that affects the brain's thermostat. Like it changes the set point of like the thermostat that's internally in your body, which causes your body temperature to fluctuate. This is usually what it's linked to. So hot flashes, they can last from several minutes to over 30 minutes. They can occur at any time and persist for different lengths of time. Some people, they have hot flashes a couple of times a week, and then some people have it like several times within an hour. It's really just a spectrum, and it's not dangerous having hot flashes outside of if we are in a heat wave, and as climate crisis is continuing and the temperature of our planet is increasing. Of course, having hot flashes when we are in climate crisis and there's a heat wave that's happening outside, the only danger that's present to you is that you're at risk of heat exhaustion and dehydration, right? So you would keep even more on top of hydrating. But hot flashes in and of themselves aren't bad or dangerous. They just feel awful because you're like, oh, I'm so warm, I'm so done with this, right? But they're not dangerous. So what can you do in order to treat them? So there's a lot of natural treatments, or just like things lifestyle wise, or even just around you that you can do that don't require taking a medication. So staying cool with light layered clothing, right? You know, like the clothing that like the long sleeve people wear, where it's a certain fabric where it wicks sweat off of you. Like, right, you would want to avoid things like wool. Like, you would try and have really breathable fabrics, even having layered bedding, right? So, not having this huge, thick duvet, which I'm so bad for doing that. I'm like, I'm so warm. And also have this huge duvet on me, but I don't want to get rid of it because it's comfortable. So I'm like, it's fine. But you probably do have to do that. Same with cooling devices. So there's like handheld things. Literally, you see people walking around with those fans, you know, and they're like kind of blowing it in your face. Wearable devices. There's cooling gel bed toppers. So like if the majority of when you're having your hot flashes is in bed, you can actually get it. It just has like a specific material that helps keep you cool in the evening. Same with like certain types of sheets, and that's because of the breathability of the sheets. Eating triggering food in moderation. So, the majority of people, if they're going to have a trigger that prompts a hot flash, it's usually from one of said things: coffee, soda, tea, chocolate, or red wine, which seems terrible because those seem like lovely things to eat. And so you're like, what? I have to reduce chocolate? I have to reduce like how much tea I drink? So one, it's related to the caffeine, right? Because caffeine changes your blood vessels. So it just kind of further makes your menopausal sweating symptoms worse because it's affecting the caffeine is affecting your blood vessels. Then there's the added thing of if it's really warm, right? Coffee and tea are really warm, so just drinking warm things is going to raise your internal temperature, which again is going to make the hot flashes worse. Physical activity, which you might think is counterintuitive because you're like, well, if I'm going to do physical exercise, I'm actually going to sweat. Like, I'm going to get really warm and get really sweat. But being active generally, physical activity generally overall, actually, like I don't know how it reduces hot flashes. I think it's probably related to your stress level, honestly. Or like if you are working out quite a bit, you're releasing endorphins, and endorphins are helping with your stress levels. And so then as a result, you're not, stress is not triggering your hot flashes, right? Because stress is a trigger for hot flashes. One of the biggest and most probably underrated things is quitting smoking. So that's like, it's a very difficult thing to do, but if your symptoms are really, really bothering you, like some people are just like, I cannot live like this, consider quitting smoking if you have been smoking, because it's probably the most impactful thing you could do for your menopausal symptoms. Like, of course, you know, there's benefits for quitting smoking for other reasons, but if like hot flashes in menopause are driving you nuts and you feel like that is like worth the potential of quitting smoking, then like that's like the most impactful thing to do. And then there's herbal remedies, which we'll talk about essentially across the board. All herbal remedies require larger studies, and I have like a little bit of an issue with this because I think we live obviously in a society with knowledge supremacy, right? So like, oh, if there's not a randomized control trial about this, which is like a really high level type of research, if that's not available, then you know it's not good, then we shouldn't do that. And I think it's like that's not actually true. If research hasn't been done, then that just means research hasn't been done. And does research like a paper saying, oh yes, this is good, and or yes, this is bad, is that like supersede your elders telling you to take muskeg tea, even though the studies are saying no, it's not going to help with menopause? I don't know, because indigenous knowledge, herbal remedies, and herbal knowledge, especially Chinese medicine, all that stuff, have existed for thousands of years. So I think it's a pretty reductive way of thinking to be like, oh, well, there's no study, so it's not going to work. Um, Technically, it could work. There's just not a study. And even if a study did say it did or didn't work, which knowledge set are we prioritizing? So this is where it's like it's a really a personal preference. The only thing that I ask of people is that if they are doing herbal or traditional remedies, is to let your healthcare provider know, just because there are known interactions with certain medications and certain plants. So, for example, black cohosh, which is probably like the number one alternative kind of herbal remedy that's available for menopause. Like when you go to a dietary store or something and you see menopause supplements, this black cohosh is probably one of the ingredients. So it is like very much used. It's in a lot of like natural health food products, and it's usually like in the form of a pill, like a powdered and then in a pill or in a tea. But like you would want to avoid that if you had high blood pressure and you were on Ramipril or an antihypertensive, right? Because those medications could interact. The thing with black cohosh is that, similar to Western medicines, like there are benefits and there are, pros and cons. I don't think something being a plant naturally makes it safer, even though there is this conception of like in health of like, well, it's better if it's a plant. And I'm like, actually, there's risks and benefits to both. So we just need to weigh those, and if the risks outweigh the benefits, then for sure do it. But this black cohosh is, like side effects could be like your stomach being upset, nausea, skin rash, infection, breast pain, spotting or bleeding outside of your menstrual cycle, right? Which then like defeats the purpose of treating menopausal symptoms. So it just really depends. But it is one of the most common things used for hot flashes. Clinical trials have shown that it is not more effective than placebo. So that just means placebo means like we were both given the same pill, but one of them was like water. Like I was telling you I was giving you this medication, but actually I was just giving you water and you didn't realize, and then you're like, oh, this helped. So that's what placebo means, is when we so, but then there's kind of a thought is like, is placebo really a bad thing? If like you're taking something and it's not causing you harm, and maybe all it is placebo, but it's mentally helping you overcome, I'm kind of like, great job. Like whatever it is that you need, I do want people to feel supported in their health journey, whatever that involves. So placebo isn't necessarily a bad thing. It's not like, oh, it's made up and it's fake and it's in your head. No, sometimes there's like spiritual connections to plants, or sometimes there's emotional connections to herbal remedies, and so it is benefiting. We don't maybe know how it is, but it is. Then just go ahead, keep doing it as long as you're not taking anything that interacts, and you're doing things in moderation. Same as anything in life, everything is usually for the most part okay as long as it's in moderation. And so there is potential, and again, but it's not super well studied, but there is potential that because this has a bit of estrogen, right? Like there's a potential that there is an increased risk of breast cancer. But that's true of just estrogen in your body anyways. Like we're going to talk about actual hormone replacement, and that is also true of anything that has excess estrogen, is that there's the potential to increase your risk of breast cancer. So, it's take what you want and leave what you don't want. But either way, just check if you are using natural remedies or plant medicines, that you're checking and making sure it doesn't interact with things, and just using things in moderation. Red clover, I do include this one because this is a part of, well, at least this is a traditional medicine that I know about and have been taught about. So, and it is a very common used for hot flashes and just menopause across the board. But what makes it helpful is this phytoestrogen and isoflavones. So phytoestrogen, it means estrogen, but it's just like a really, really weak form of it. And it's really only in like the little pink fits. So clover, red clover, most people within Ontario, like you've seen this plant before, or you have it in your yard, or it's kind of like grows with dandelions, or it's kind of available in a lot of different places. I remember as a kid, we would pick these and then eat the little flowers. So it's in that sense, it's people have had a lot of exposure to it. Um, and so there is some evidence that red clover helps reduce menopausal symptoms like hot flashes, but the research was mixed again, like everything, and the placebo was just as effective. But, if you were to use it, this is definitely relative to herbal remedies for menopause. This one is probably less risky than black cohosh or any of the other things that I've talked about because the level of estrogen within it is so small, right? So does it have the potential to help? Yes. Will it? I'm not sure. It really just depends. Um, Also, red clover usually doesn't have a lot of side effects, and it is approved by the FDA, and there aren't really a lot of interactions. If there are, it's going to be things containing estrogen. In which case, that's the reason you're taking this. Is in order to treat hot flashes, you essentially give yourself more estrogen, whether that's in the form of a plant like red clover or that's in the form of a birth control pill. And getting estrogen, that is usually a common way that people treat their menopausal symptoms. But I just find that it just has less interactions, red clover, relative to other things. And at shoppers or any sort of even not just like natural like food stores, even just like a regular Shoppers or Safeway has organic red clover, the traditional medicinals. That's like a tea brand that I'm pretty on board with, just because I've like done a bit of research and I'm like, okay, I'm not getting paid to say that either. Like I wish they would give me free tea. That would be a really nice form of compensation for all the tea that I buy from them. But this is like federally approved, and it seems to be a brand like has a lot of different traditional medicinal ingredients. And I, for the most part, trust it in terms of its production. But how would you use red clover? So 1 to 2 teaspoons of dried flowers or flowering tops steeped in a cup of water for half an hour. Drink 2 to 3 cups daily. Or if using a tea, you could just use this one tea bag. Again, do I recommend that everyone who has menopausal symptoms go and use this? Not necessarily. But if the symptoms are really, really bothersome, you want to do something and you're really against hormones, then like consider these other options. Just because there's not as many serious side effects. And if they are, there are things like nausea, headache, rash, which I'm like, on a daily, I have those things without taking any medication. So it's kind of okay. But just a caution that if you are on blood thinners or, if you have cancer and you're taking tamoxifen, which is a cancer treatment, you would want to avoid this. But again, the way to do that is to ask your provider or to Google it. But that's kind of the way to check if interactions are occurring. Back to this quitting smoking. So people know in my talks, like I don't really hound this very much. I probably should a bit more as the family doctor, really be like trying to prompt people to quit smoking. But I find that like I offer it to people, and if they don't want to, then they don't want to. And there's no like, there's things within substance use and addictions that's called like the stages, like pre-contemplative, contemplative, versus in recovery or active. And so people, if they have interest in this, then I will help them pursue this. But for the most part, I'm not very prescriptive about quitting smoking. There are a lot of health benefits, and this would help your health overall, not just menopause. But there have been women who have been my patients where their hot flashes were just so bad and they couldn't take anything estrogen based because they did have a cancer. So if they took estrogen, they would actually be feeding the cancer. So like they couldn't take even any of the natural remedies that I was talking about because that would have the potential to make the cancer worse. And their hot flashes were so bad, they couldn't take anything traditional or not. Or Western, so they're just. I was like, well, we could try quitting smoking. Like that seems to really affect with hot flashes. She was like, whatever, man, I'm just gonna do it. I'm just gonna do it, even though, and like that's actually what prompted her to quit smoking because she was just so tired of the hot flashes. But it definitely can, like, and I think how it does that is because cigarette smoking, when you're not doing it, essentially decreases the levels of bioavailable estrogen. So what happens when you quit smoking? So sometimes it's helpful for people to like, because any amount of time quitting, because that was another thing. They did this study of like, is there like how much time would you have had to quit smoking in order to have a benefit to your hot flashes? And really, they've shown that any amount of quitting smoking has the potential to positively impact and for you to not experience as many menopausal symptoms or hot flashes. But things that can happen. So, after 8 hours of not smoking, right, you've quit smoking for 8 hours, your oxygen levels are recovering, the harmful carbon monoxide level in your blood will have reduced by half. Right, that's significant. Like if you just like even went a couple of days, right, like the carbon monoxide level in your body reducing by half, that's a pretty significant improvement. After 48 hours, all carbon monoxide in your body is flushed out, your lungs are clearing out, the mucus, your sense of taste and smell are improving. After 3 days, 72 hours, breathing might feel easier, and that's because essentially your bronchial tubes have started to relax because it's no longer being strained by tobacco or nicotine smoke. Your energy might be increasing after 12 weeks. Like literally your heart and your blood vessels start to improve, so your circulation improves. And then after 3 to 9 months, for the most part, like coughing, wheezing, breathing problems will improve by at least up to 10%. Right? So there is the potential for a lot of things like that to help. Another thing that people don't often think about, but is an option, especially for hot flashes, is actually SSRIs or SNRIs. So SSRIs are selective serotonin reuptake inhibitors. Those are like depression and anxiety medications, which is like you think like, why does that work? I honestly don't really know, and I don't know that anyone knows the mechanism as to why these things work, but they do. Like it's been shown that specifically these two SSRIs, paroxetine and citalopram, seem to really help with hot flashes, and then SNRIs like the venlafaxine. Um, and yeah, I think there's like I don't know exactly, but the symptoms of taking those medications, right, is maybe feeling like a headache or nausea or some constipation. But if there's a potential for it to improve your hot flashes, they've just done a lot of studies and it seems to do that. And I don't know why, but it does. And also because your depression or anxiety might be getting worse in menopause, it might have a dual purpose, right? It actually might be helping with some mood issues, and might be also helping with the hot flashes. So it is something that is available. Will hot flashes last forever? The answer is no. And that's because, before you've hit menopause, ovaries are the main things releasing estrogen, right? It's working. It's the ovaries are releasing and they're going to the different places they need to. Eventually, your ovaries, they will run out of eggs, they will run out of follicles, and they won't produce estrogen anymore. But over time, your body starts to get used to that estrogen drop. And as your body gets used to it, in the background, there were other organs in your body that were producing small amounts of estrogen. Maybe not like the most strongest forms, but for example, like your adrenal gland, it releases estrone, which is released from body fat, right? So you get estrogen from your body fat, from your adrenal gland, which is the like little hat-shaped organ that's above your kidneys and is in charge of really like your stress, flight or flight response, which is another topic in and of itself, which is people with high levels of stress are more likely to enter menopause earlier. And that's because the thing that would have been helping them in the background, right, that little bit of extra estrogen, their adrenals are already fatigued because they were already stressed for like most of their life. And so like now their symptoms for perimenopause, postmenopause, menopause is like just worse. And that's because that little extra estrogen they could have been getting, it's been fatigued because they've been stressed all of their life. But the majority of menopausal women, like 80% of people, will have hot flashes for less than 2 years. So if you do have them, are you stuck with them forever? No. Majority of people, it's going to end within about 2 years. And if that's not you, 20%, the others may experience it for up to 5 years. So it kind of just depends where you sit in that category. So something I do want to make sure that we have a chance to talk about is hormone replacement, because I think there's a lot of misconceptions, and I think it's like a topic where especially like Indigenous communities might be a little like, whoa, like I'm not taking hormone replacement for that. One, because we don't necessarily like taking medications. I myself don't like taking medications. And I for sure fit into that bias of like, if it's a plant medicine, it's more like it's more healthier. If it's a natural remedy, it's more healthier. I think that's just like a bias I have having grown up around traditional medicines. But I have seen hormone replacement really change women's lives. Like, especially if you are suffering with any of those symptoms I've talked about, nothing's helping, it's affecting everything in your life. Like, I actually do think it's worth considering hormone replacement. It comes in a lot of different forms: cream, patch, spray, pills, gel, right? Different forms of the hormone replacement are going to absorb differently, so they're going to have different side effects, and they may, like some forms of it, are even better to reduce your risk of breast cancer, and some are a bit worse, right? Like there's all of these different caveats, but usually if the reason why you have symptoms in menopause is because decreasing estrogen and progesterone. So hormone replacement, there's usually two purposes: either short-term relief for menopausal symptoms, right? Because for the most part, on average, if you are taking start hormone replacement, like estradiol, for example, which is just straight up estrogen. If you started taking that, usually about every 5 years, you want to kind of do the quick math of like, is this worth the risk? Like, is the benefit worth the risk? So you don't want to be on hormones forever. I have had patients who've been on for 20 years and they're like, don't you dare take this away from me. Like, I already know the risk of heart attack, stroke, clot, whatever, but like, my life has improved. I'm not peeing myself as much. I can actually think. I'm not having hot flashes. My husband doesn't want to kill me. There's like so many benefits. So like, don't you dare take me off the hormones. But in practice, you're every 5 years supposed to kind of do like a check-in about, okay, is this helping? So some people do it for just the short-term relief until you're in that postmenopause phase where other forms of estrogen are starting to kick in. You just do it for a little bit of time. And some people do it for like long-term prevention of diseases that arise from aging. Like, that's actually a reason that some people might start hormone replacement. So there's usually there's many forms of estrogen, right? And then there's the estrogen itself, and then the estrogen and progesterone. The one that's right for you, just talk to your provider about it, but it is usually related to if you have a uterus or not. So because, right, if all we were doing was increasing estrogen, boom, 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 just increasing it, right? There's a chance that, and you have a uterus, right? The endometrial lining is going to thicken. And so then you do have a higher risk of endometrial cancer versus when you give two of the things, right? If you give estrogen and progesterone, they kind of balance each other out. So you're not just having this like nonstop thickening. But again, you might not get that thickening depending on the dose of the estrogen that you're taking. But the benefits. So, one, alleviating menopausal symptoms: mood swings, depression, vaginal dryness, hot flashes. It prevents osteoporosis, which that's so osteoporosis is a thing that all women will at some point have to think about or battle with. It's inevitable. One, because we live in Canada, so we have really low vitamin D levels. Two, majority of people are starting to become lactose intolerant, and so they're not actually getting high calcium intake. And three, when you have less estrogen in your body, your bones start to become brittle and weaker. So actually, by taking hormone replacement, like being exposed that extra 5 years because you started birth control, once you hit menopause, actually has a lot of benefit in terms of preventing your bones from getting weaker, right? Like, your bones will stay stronger for longer, and you're less likely to get a fragility fracture, which is, I don't know, like when you hit something and you're like, ah, it broke, and you're like, I didn't even do anything. That's what a fragility fracture is. Happen in your spine and your hip, all of these things. So that's a benefit of taking it. The other is cardiovascular health or heart health. So interestingly, taking hormones like estrogen, progesterone reduces your chances of heart disease, especially if you start it soon after menopause. It's almost like the hormone replacement acts as like an extra layer of protection for your heart. So then you just have less heart related problems. So in women age less than 60 years old, or within 10 years essentially of menopause, and they had no evidence of cardiovascular disease, starting hormone therapy is actually like there's the risk of it is actually quite low in terms of heart related issues. Um, it depends when you start estrogen though. So what I will say across the board is that the later you are starting hormones within that change, anytime within that transition, the higher your risk of anything is. So it's kind of like people are like, well, maybe I'll just wait a bit to see if the symptoms, but if it's like, you're 10 years out from when you hit menopause and you're like, I want to start hormones, and like, ooh, that is like I'm like, I don't know if that's a good idea. Like I would probably try and do some talking and discussing to be like, are you sure you want to do that? Um, because it's kind of like when you first have menopause, right? The risk for you is lower. There's also, so, being on hormones can actually decrease your risk of heart disease in women. And it can actually reduce your cholesterol levels or help your cholesterol levels stay low. Should people start hormone replacement just so they can, have a bit of extra percentage to reduce the risk of heart attack? I don't think so. That's not recommended. But if it was treating menopausal symptoms and you're getting this added bonus, then for sure. But with the cholesterol, it does help your body keep it within a healthy range, which might be helpful because when you have less estrogen because you're menopausal and you're potentially gaining weight, like I said, gaining weight in and of itself isn't bad. But if the cause of that weight gain was like junk food, then you have high levels of bad cholesterol, right? So then you're kind of making that situation worse. So this has the potential to actually improve that. There's also the cognitive benefits in Alzheimer's disease. So definitely recent research suggests that hormone replacement can actually lower your risk of Alzheimer's disease. But I mean, again, more studies are needed to absolutely be sure of these effects. But definitely they have looked at that. Like the people who were taking hormone replacements had better scores on tests in terms of like memory, being able to remember things compared to the people who didn't. Hormone replacement does have the potential to actually keep your brain in good shape, especially as you get older, and improved quality of life, right? Just generally across the board, people seem to do better and feel better when they're on this. Some cons and potential drawbacks or risks of hormone replacement therapy, again, are these risks of breast cancer and endometrial cancer. So some forms, and it's actually only some forms of hormone replacement, not all hormone replacement increases your risk of breast cancer. But it's usually your risk of breast cancer is more related to how many years you've been using hormone replacement and less so when you started it and or what kind you use. It's kind of like length of time. Hence why there's a bit of this like unsaid spoken rule about like, 10 years of using hormone replacement therapy, like maybe consider stopping. The endometrial cancer, again, that's only when you use estrogen, right? If you have estrogen and progesterone, you're not really increasing your risk of endometrial cancer. But there's the potential consequences of that. And I'll kind of show images of what exactly those risks are. And you'll see that they're not all that different than just your average risk of being someone who smokes or just being a woman. It's actually, it's not as bad as it seems, but the blood clots and stroke risk, that is something that hormones do have the potential to increase your risk of that. And the next slide talks about like what would put you at a higher risk for blood clots and stroke. But I think when I think of like potential drawbacks or like risk benefit, the real risk or drawback I see is probably related to blood clots. But there's studies that if you started early and you didn't have any of the risk factors, like you didn't have like obesity, your cholesterol was normal, your blood pressure was normal, and then you started hormone replacement therapy, your risk of clots, I don't know, it's pretty like it's okay. It's not that much more risky than you just existing in the world. If you were someone who had diabetes, had bad cholesterol, maybe you have a history of like stroke within your family, and now you're starting hormone replacement, and maybe you started it like a bit later, like you're 60 and now you're doing it, I'd be like, there's a lot of risk involved in this. Doesn't mean there's not benefit, but you would definitely need to be informed about that. And then the potential side effects, right? People who are taking hormones, like we talked about, estrogen can potential to increase weight, nausea, headaches, mood changes, um, and it's kind of confusing because I just said in the previous slide that taking hormone therapy has the potential to improve your heart health, which is true. But if you're taking it and you've been taking it for more than 10 years and you're quite like you're 80 by the time you're trying to start taking it, it's your first time, then actually your risk of heart disease increases. So timing is really key. And the weight gain also in this potential side effect is varies, and it's usually like a few pounds or less. Um, yeah, so this is some of the things. One thing to know is that if you did start taking hormones, and then say, for example, you're at the 10-year mark, you're like, okay, I'm going to stop this for a bit, you probably will have a difficult time stopping hormone therapy in the same way that you would have had a difficult time starting, like, hitting menopause, if that makes sense. So it's kind of like you're keeping estrogen in your body for longer, but eventually the time and the moment in time in which you don't have that estrogen, whether it's naturally from your body or because you were taking it, like it is going to suck stopping it because you'll have felt really great and then you stopped and you're like, which is what menopause is. So it's kind of hard to get around experiencing menopause, but this is something to consider, is that, this is the drawback, this is the potential risk. So these are the things that I was talking about in terms of like, okay, should you maybe consider not being on hormones because there's a higher risk of that clot, which I think that's really the only one I consider, because I'll show you the next slide about endometrial and breast cancer. And I'm like, I don't know. That's a theoretical risk and it seems to not be super bad. Like I myself would look at that and be like, that's not for myself a reason why I would stop using it, but this is. So avoiding, if you have known coronary artery disease, like your arteries are clogged, you've had a stroke in the past, you have had clots in the past, you have blood cancer or breast cancer, sorry, you have a clotting issue, or this is like your ASCVD, is like your cardiovascular risk calculator. You can actually Google ACCVD risk calculator and figure out the percentage, right? So if it's greater than 7.5%, that means you already have a high risk of heart attack and stroke. So adding hormones is going to make that risk higher. Is there a question? Two. Okay, let me answer them because we're running out of time. How does mercury affect menopause? Yes. So the side that we were talking about in terms of environmental impacts, I definitely think of people who suffer from mercury poisoning, especially in like our region, people in grassy narrows or anyone who's kind of experiencing those things, and it is likely to affect menopause. And it's usually either you get menopause really, really early because the environmental toxins have like affected your fertility and the endocrine system, right? Mercury affects things like your thyroid and your endocrine system, which is like your hormones in your body. So you're more likely to experience menopause sooner, which is unnatural, and or have it for longer, which is unnatural. So it's kind of it for sure does affect that. And does physical activity help hot flashes the same way hot tub effect works? Using hot tub makes pool feel colder. That's a really interesting question. Does physical activity help hot flashes the same way hot tub effect works? We use a hot tub and it makes the pool feel colder. I don't actually know about that. That would make sense. So people don't actually know the mechanism as to why physical activity helps with hot flashes, but that actually would make a lot of sense to me. But I'm not actually sure about that. I'm not 100%, so I don't want to say yes or no the either way. But that's really smart. I'm like, oh, that would make a lot of sense. So I don't know. That's what I would go with, but I'm not sure. Um, yeah, and so just your risk of the potential risk is higher if you already have heart, stroke, cholesterol problems. And lastly, just to talk about some of these like effects and what we mean when we say, I'm just going to change this. Um, the risks of breast cancer, like, oh, you're going to get breast cancer if you take hormones. Well, if we just looked at a baseline, if the, just the rate, just by existing in the world, 23 cases of breast cancer were diagnosed within 1,000 people per 1,000 people over the next 5 years, right? Regardless of what we're doing, there are going to be 23 cases out of 1,000 over the next 5 years of people developing breast cancer, whether we took hormones or not, right? So there, in addition to those 23, just by random chance and crappy luck, um, 24 plus 23, the risk of more people, 24 extra people are added to that 23 number if there is an obesity. So that's great BMI greater than 30%, 30, and that's more related to people's cholesterol, right? So if you already have that, you're sort of adding to the risk. 5 more cases gets added if someone was drinking 2 or more units of alcohol per day. 3 more cases or 4 cases are cases in women on combined hormone replacement therapy. So you can kind of see there's a lot of other risk factors that contribute to your risk of breast cancer more so than the hormone replacement. Like obesity, how much you drink and how much you smoke almost has like more, if not the same amount of risk of developing breast cancer as a result of that hormone replacement therapy. And the way to like mitigate that risk is actually just by getting mammograms regularly. And there's been new provincial changes where now people 40 and up can self-refer for their own mammogram, regardless of cancer. Before it used to be like you had to prove like that you had a cancer history, maybe you had the BRCA gene, all of this stuff. But like as of like 4 days ago, I think a week ago, the Ontario provincial guidelines have actually changed, and you could be 40 years old and self-refer for your own mammogram. Right. But otherwise, like the regular screening before used to be like 50 to 79 every 2 years, but now it's actually decreased down to 40. So at any point, 40 onwards, you could just get a mammogram. Yeah. Which is kind of nice because then you just know, right? So that's how you mitigate the risk of breast cancer is by getting the screening done. Okay. So maybe we'll just end with this last point, which is healthy, just related to healthy aging in general, especially people who are menopausal or this perimenopause phase. And it's really related to calcium and vitamin D. Like as part of like women's health, that is something that I recommend to all women across the board, as long as they don't have like, don't take extra calcium if you have cancer or, but the risk of taking calcium, most people are really low. 1.2 grams or 1,200 milligrams, whether that's from diet or supplements, will increase your bone health. You will have a lower risk of osteoporosis, and osteoporosis just sucks. By weight-bearing activities, that means like holding a can of soup and literally walking around, right? That's gravity pushing down on you. And so your bones have to work against gravity to do something, whether it's walking or whatever it is. So the bone breaking down actually helps it rebuild. So exercise, especially weightlifting, if you're trying to prevent osteoporosis and you're trying to be like age well in terms of this menopause transition, then do weight bearing exercises, take 1.2 grams of calcium and vitamin D, like at least 1,000 international units, just because being in Canada, it would be impossible even if you were naked outside all day to get all of your vitamin D from the sun. Like it's just, we don't, at the altitude we live, it's not possible. So everyone is low in vitamin D and needs to take vitamin D, including myself. And especially if you have brown skin, it's even worse because then the melanin makes it hard for you to absorb sunlight. So just take vitamin D. And that's probably where we'll end. Okay, sorry for going over a bit, but I'll hand it back over to Kate.
Am I good to go? Perfect. Hey, everybody, just want to say a big thank you for those who joined us this afternoon for this Women's Health Talk. And thank you very much to Dr. Alexa for sharing your wisdom with us. I learned a lot. I thought that was really cool. And then just a reminder that we will be posting the survey link, and you will have until Friday to fill it out. And those of you that do fill it out will be entered into a draw to have a chance to win a self-care bundle. And I believe that is all.
Next Women's Health Talk series.
I don't know off the top of my
Do
head.
you know off the top of your head? We'll post it on the like Facebook Live event and just on in the chat function, just to, because there is another Indigenous Women Health Talk series in November. Don't know the date or what I'm talking about, but it will be posted. Okay. Thanks, folks.
Yeah, I don't think I could pull it up really quick.
Okay.
Yeah, we'll post it.
We'll post it.
Yeah, otherwise you'll be waiting for me.
Okay.
Okay.
Say November 14th.
Oh, okay.
So November 14th at 2 p.m.
November 14th, 2 p.m. diabetes. Okay, that's what I will be talking about. I will see you then.
Perfect. Bye, everybody.